We know that the birth of your baby is a hugely anticipated event, filled with feelings of lots of excitement but also apprehension too. The aim of this session is to provide you with information about the stages of labour and the birth process, and also what to expect from your care providers during the birth of your baby. Prior to getting started on all of that, we'd like to talk to you firstly about pre-birth preparations. We'd like you to remember that your due date is only an approximation of when your baby is to be born. You are full term from 37 weeks gestation, and therefore we recommend that you pack a bag from around 34 weeks pregnant. You need to pack things for yourself, such as clothing and toiletries, and also pack for your newborn, including clothing and nappies. You may also wish to bring any home comforts or any snacks that you wish to have during labour. It's also important to ensure that you have transport to get to our hospitals. An ambulance should only be used in the event of an emergency. Therefore, it can be a good idea to familiarise yourself with your local maternity unit and where the labour wards are, both at Pilgrim and at Lincoln. Many of you will have childcare provisions to sort and arrange prior to the birth of your baby, and some of you will have animal care provisions also. During the coronavirus pandemic, birthing partners are only allowed on the labour ward and no other visitors allowed on M1 at Boston or on Netland ward, which is our antenatal and postnatal ward at Lincoln. So, stages of labour. But prior to getting started, we've been over birth preparations, and we'd just like to point out and reiterate that as with your pregnancy, your labour and birth is unique to you. Everybody's is different. It's also important to note that your waters going are no indication as to what stage of labour you are in. Sometimes your waters can break, so your membranes can rupture prior to the labour starting. More often they do go during labour, and sometimes your babies are born in their membrane sac. However, it's so important to let your local maternity unit know if you think your waters have gone. So, the latent phase of labour, often referred to as early labour, and this is defined by irregular uterine activity and when your cervix is less than 4 centimetres dilated. The latent phase of labour can be different for everyone. It can last sometimes for hours and sometimes for days. More commonly, women experience things such as period-type pain, backache, sometimes a lack of appetite, loose stools, and sometimes nausea and vomiting. Your body is doing a lot of work during the latent phase of labour. Your cervix is thinning, softening, moving position and starting to dilate, and your contractions are getting established. More commonly in latent phase, the contractions you experience are what we call irregular. This means that they can vary in length, so some may be shorter than others. They can be different in strength, some may feel weaker, some may feel more powerful, and there's often different spacing between them, so sometimes there may be a 2-minute gap, sometimes there may be a 10-minute gap. During the latent phase of labour, it is often best for you to be at home during this phase. Sometimes if you come into hospital too soon, when your labour is not established, we may send you home again. There are various different things you can do to cope during the latent phase of labour. You may wish to have a warm bath or a shower. You may wish to get a massage from your partner or birth partner. Aromatherapy can be really helpful. Breathing and relaxation exercises, TENS machine and paracetamol. The first stage of labour. This is when your body progresses from the latent phase and you are now in established labour. The first stage of labour is defined as regular uterine activity when your cervix is more than 4 centimetres dilated, all the way up to 10 centimetres or fully dilated. What we mean by regular uterine activity is when your contractions are regular, coming 3 to 4 times in a 10-minute period, and they are long-lasting, so roughly over 45 seconds, sometimes up to 60 seconds long. The contractions you feel when you are in established labour often feel more powerful and more intense than they did in the latent phase of labour. The first stage of labour can vary in length, often your first labour being longer than subsequent labours. As with the latent phase of labour, in the first stage of labour, we really emphasise the importance of hydration and food intake if you can. Mobilising, keeping upright and adopting different positions is also really beneficial to the progression of your labour. So, what to expect when you arrive on labour ward? The midwife will allow you and your birth partner a bit of time to settle into your room, provide you with refreshments, show you where your nearest bathroom and toilet are, and also make you aware of the call bell system. Once you have settled in, the midwife will then get a short history of your pregnancy and see how you've been coping during your labour so far. She will then perform a routine antenatal check. This is simple things that happen in the community as well, such as doing your blood pressure, measuring your pulse and temperature. She will also offer then an abdominal palpation. This means having a little feel of your tummy and seeing what position your baby is in. During the first stage of labour, your baby's heartbeat can be monitored in one of two ways. The first is via intermittent auscultation using a handheld sonic aid device, or using continuous electronic fetal monitoring, also known as a CTG. A vaginal examination is not a routine element of care on admission to labour ward, but is usually performed within the first 4 hours of your admittance. Remember, everything in your labour is your choice and can only be performed with your consent. The second stage of labour is when your cervix is 10 centimetres, often referred to as fully dilated, until the birth of your baby. Being fully dilated does not always have to be confirmed by a vaginal examination, and often your body lets us know that you are ready to have your baby. Signs of this can include the urge or need to open your bowels, an urge to push, or a change in alteration or transitional emotions. When your cervix is fully dilated, this is when your baby's head or bottom moves further down into the birth canal. You may not feel an urge to push straight away, but often this feeling becomes instinctual. On occasions, such as if you have an epidural on board, you may not feel that urge to push, so the midwife may guide you during this. When your baby's head is at the opening of the vagina, this is called the crowning stage. Often, your midwife will call another midwife into the room. This is just an extra pair of hands, and to note things like the time of birth. This is routine practice for all births and nothing to worry about. When your baby's head is ready to be born, often the midwife will apply pressure to the perineal area or a warm compress. This is to reduce the risk of tearing. When your baby's head is crowning, it is also really important to listen to your midwife as she will guide you through this process. We want you to birth your baby as gently as possible, and so we encourage the gentle stretching of the perineal muscles. Once your baby's head is born, there is normally a short wait for the next contraction, usually a minute or two. Then with the next contraction, your baby's body is born. It is routine practice for us to offer you skin-to-skin contact straight after your baby's born. This means that the midwife will place the baby straight onto your chest. Skin-to-skin is so important, helps with the control and regulation of your baby's heart rate and breathing, and also helps with the initiation of breastfeeding and attachment and bonding. So, the third stage of labour, you'll be pleased to hear it's the final stage of labour, and most people don't realise that this is actually a stage. But this is after your baby is born, and the third stage of labour refers to birthing your placenta. The placenta is the little lifeline that has kept your baby alive for all those months inside of you and plays a massively important role during your pregnancy. Immediately after birth, your womb contracts, so your uterus contracts down strongly, and then your placenta separates from the uterine wall. There are two options for the birth of your placenta. These include active management or physiological management. Active management is when an oxytocic drug is administered into your arm or your thigh immediately after birth. This helps the uterus contract down. The midwife will then clamp the cord and then offer your partner or birthing partner to cut the cord if they wish. If not, you can cut the cord yourself or we can cut it for you. After this, when the placenta is ready, the midwife will guide it out using gentle traction on the cord. The other option is physiological management, often when we don't cut the cord and you birth the placenta yourself. This can sometimes take a little bit longer than active management. Options for the delivery of your placenta are often discussed during your antenatal period. It is your choice based on recommendations and what you feel comfortable with. Sometimes one method over the other will be recommended. Following the birth of your baby and after the delivery of your placenta, the midwife then needs to perform some routine checks. The first of which is to assess your perineal area. This is to see whether you need any stitches or not. If you do, these are usually performed by a midwife in the room, but sometimes performed by a doctor. Your midwife will then check over your baby, do your baby's head circumference, and also weigh your baby. We then offer some additional screening tests for your baby. Details of these can be found in your screening booklet, and these include pulse oximetry, hearing screening, and the newborn infant physical examination.